I'll present my case series where I think that robot has been invaluable in cases like this. So the series is about post-traumatic osteoarthritis, maybe with any periprosthetic intra-articular knee trauma or previously conducted high tibial osteotomy. These are the cases we get around 2% of our primary practice, and a CT-based robotic system is very valuable in conducting primary knee arthroplasties in such cases. So the challenges in such cases I found is difficulty in the planning. The surgical time can increase if we go on removing the whole hardware, which leads to high risk of refracture, higher blood loss. It may increase the use of higher constraints in the primary knee systems and may lead to higher risk of instability and failures. This is a couple of cases where previous hardware was there by a high tibial osteotomy, and conventional knees, primary knee was done. But on radiological and clinical outcomes, the results were not as good as one would expect from a straightforward knees. So this is another example where a primary knee valgus was, we did a primary total knee replacement, but because we could not insert a femoral zig, so we had to remove the whole nail, and then just to secure, we had to put in a extra rod in the femur. Now, what is the advantages of using a CT-based system for doing such cases? The planning is precise. We can get accurate alignment. There is more efficiencies dealing with the extra-articular deformities. We can size the implant better, place the implant in much more better, we get better real-time feedback. There is less soft tissue damage because we can constrict the use of the soft tissue release in such cases. There is lesser chances of using higher constrained joints. We have less blood loss in such cases and would lead to faster recovery than otherwise. So this is an old patient, above 70, had a intra-articular tibia fracture 30 years back. So removing a 30-year-old hardware is itself a tricky job. So in such cases, you can see there is malalignment of tibia as well. So we use a Mako robotic system in this case. With the CT planner, we could identify what is the minimum amount of hardware we can remove and place in the good, in well-balanced knee. So I could identify on coronal and sagittal views, only 2 screws needed to be removed, and we could get very good fixation in such cases. And just comparing, we did a bilateral in this case. So compared to right, the left, both were equally good. The patient was very happy. There another case where a patient had 3 years back distal femur fracture. After fixation, had post-traumatic osteoarthritis along with a good amount of stiffness, and she had a very high amount of osteoporosis as well. So removing the whole hardware, putting in rod in the femur would lead to be an extensile surgery, extensile blood loss. We avoided by using the same system again, and I could identify all the hardware where it would come in between. We went in with a CR knee, didn't remove a single hardware in such case. And we had an equally good result on this bilateral as well. So this is a rigid, uncorrectable valgus knee fixed a few years back. You can see on the lateral view of the femur is malaligned. So even if you remove the plate and do a intramedullary rod for the femoral cut, that would be also tricky in such cases. Here had the same experience, could get good analysis of the femoral hardware, did not remove a single screw, and got good outcomes. This is a case with bilateral high tibial osteotomy, progressed to arthritis. And now the patient wanted a total knee. So in this case, again, we could identify the hardware from the anteromedial side. A couple of screws are removed, and Unfortunately, on one side, the screws, the head was not able to remove, so we had to remove the whole plate on one side, and the other side we could do it normally. In this case, where we removed the whole hardware, the patient had long-term synovitis post-surgery, had a lot of higher pain scores. We don't know the exact reason, but mainly because of the extensile approach, maybe for removing the plate, the recovery time was little longer. In a case of a distal femur nail was done. You can see there is some malalignment of the femur. So if you remove the rod and do intramedullary femoral nailing, then also the alignment would be little difficult to capture. So here again we could identify the hardware previously inside and would get excellent outcomes without removing any single hardware. So this is a very young patient who had a ACL reconstruction, MCL reconstruction, and also was in a valgus knee. So we had to go for a total knee in this case, and we could identify the gap balancing was much more secure. No ACL fixation screws were removed so not to disturb the PCL as well. We could do a CR knee in this case, which would have been otherwise very difficult, and we got good alignment. Same with along with femur, we can with the tibia rod also. You can identify the type of slope you can do and control it in a way where without disturbing the tibial nail, and you can position your tibia like medializing, lateralizing, undersizing, correct sizing as per the requirement based on the previous hardware, and you can get away just like a normal primary cases. So this was again a very stiff, rigid, uncorrectable valgus knee. Patient had a severe FFD as well in this case. To get good alignment in such cases is very difficult intraoperatively when you go in for such cases. Even with the robot, we had a little bit of struggle in exposure and all. So eventually we get great outcome in these cases. The amount of literature in this aspect is very limited. I could find very few case series. One is been published by Dr. Rajesh Malhotra from AIIMS and his group. Rest, most of the literature is based on some case reports. So to summarize, what value I found with the CT-based robot is that we can reduce the amount of hardware removal. It is less time consuming. You can say it is as good as a normal primary. It is effective in producing good alignment. It decreases my rate of infection otherwise in such cases. Iatrogenic trauma can be also reduced, and the higher constraint knees can be avoided in such cases. Thank you.